about the pharmacokinetics and pharmacodynamics of antibiotics, particularly for gram-negative infections in the critically ill. This talk is sponsored by Pfizer, and as a result, they haven't interfered with the slides or the content. They don't take any responsibility for anything I say or that's in the slides, but I must declare the conflict of interest. If you look at the big title up there, it also can be summarized into the subtleties of pharmacokinetics and pharmacodynamics, or even more simply, drug level over MIC for gram-negative resistant organisms. So let's start off with some background. Pharmacokinetics describes the concentration time profile of a drug, and in this case, antibiotics. So if I give you a drug, there'll be a rise in concentration up to a peak, and then there'll be a fall off depending on volume of distribution, clearances, etc. Pharmacodynamics, though, correlates that yellow curve or the concentration of the antibiotic with its ability to kill or inhibit target pathogen. So, dose concentration is pharmacokinetics, concentration effect is pharmacodynamics, and PK/PD relationship is dose effect. Another way of looking at it would be pharmacokinetics is what the body does to the drug or the antibiotic, whereas pharmacodynamics is what the drug does within the body. So just looking at pharmacodynamics, the concentration effect or the ability to kill is not that easy to measure. It's easier to monitor the pharmacodynamics of noradrenaline. You just titrate to a blood pressure, or the pharmacodynamic effect of insulin, and you monitor glucose. So understanding the PD of antibiotics revolves around understanding the kill characteristics of antibiotics. And if you look at the right-hand column over here, if this is colony forming units on that axis, and that's time on that axis, and that's the growth of a control organism in a test tube or in a thigh model of infection. If you give a little bit of aminoglycosides, there'll be a kill like the green curve. If you increase the dose at the infection site of the aminoglycosides, there'll be a quicker and a more continuous kill. And that's called concentration-dependent killing. However, the beta-lactams particularly don't react like this, and if that's colony-forming units, and that's the control arm, if you add a certain concentration of the beta-lactams, there'll be a slow, continuous kill. If you increase the concentrations, there'll be very little increased kill. So those are time-dependent or non-concentration or time-dependent kill characteristics of the beta-lactams. So going back to that yellow curve, if you plot the pharmacodynamics or the MIC, the beta-lactams need a time-dependent or a long time above the MIC, whereas the quinolones or the aminoglycosides need a high peak, Cmax to MIC for their optimum kill. So let's look at the pharmacodynamics. I'll come back to the pharmacokinetics a little bit later, but let's look at the pharmacodynamic parameter of these PK/PD or the MIC, to be more specific. You can measure the MIC in various ways. There are diffusion and dilutional methods. The most common diffusion method and the most accurate would be the E-test, whereas that most people will use dilution agar or microbath in a big machine, a Vitek machine, for the determination of the MIC. And just to point out, there's no single method that is correct for all the drug-bug interactions for the MIC determination. So this is an E-test. You put a strip into a growing organisms, and the MIC here will be about 1. It's not always that clear, though. Here is another e-test, and we don't really know where the MRC is over here. Here's another one. Again, it's not this nice round curve that'll give you an optimum reading of MRC. And if you put it into the machine, the Vitek machine is one of the more common ones, again, it's not that accurate. This is a very important article by Johan Mouton, who unfortunately died recently, and John Turnage from Australia, looking at the myths of the MRC determination. And the main message I got out of this article is that in a laboratory with the same technologists, the same machine, there can be a twofold difference in variation from one day to the next or 1 hour to the next in the same determination of that MRC. So MRCs are not accurate. Well, not that accurate. But once you've got MRCs, you put a whole lot of MRCs together to get breakpoints. And this is a distribution of MRCs over a large series of organisms that will give you this breakpoint. And usually there are two distinct populations. There's usually a susceptible population and a resistant population, but there may be an intermediate population of moderately susceptible or equivocal results. So if you look at these big databases, this is a European database of MRC distribution, and you can see there are sensitive organisms and there are resistant organisms. So those would be regarded as sensitive and those would be regarded as resistant. But it's not always as easy as these breakpoints over here. You may get a whole lot of MRC results like this, and you think that's arbitrarily determined that that would be resistant organisms. Anything above 0.25 would be resistant, whereas those would be the sensitive organisms. So this would be Kefir, and this would be against E. coli. Anything above 0.25 would be regarded probably in the breakpoints as resistant. So the MRC is an MRC, whether it's accurate or not is an MRC. Breakpoints is the interpretation of large databases of MRC into resistant, sensitive, or intermediate organisms. And there are different breakpoints for different antibiotics against different organisms. So there you saw 3 different breakpoints for various organisms against the antibiotic. And then it becomes more complicated because there's no internationally agreed breakpoints yet, although I know the microbiologists and ID physicians are trying to collaborate and create international breakpoints. So there are different European breakpoints, UCAST, as against the American CLSI breakpoints. And that just complicates the picture a little bit more. So breakpoints are relatively arbitrarily defined, and there may or may not be a consistency in some organisms against some antibiotics. So let's just look at the slide again, this yellow curve of concentration over time, and plot an MRC, which here would be MRC of X, of 0.25, for example. And that would be the time above MRC. But as Mouton and Turnage in that article showed, there could be a dilution of 2 different, so that actually the organisms may be less than 0.25, maybe 0.125, in other words, half that level. Or on the, and that would be the time above MRC, which would be very good. But if that X is not X, but maybe 2X because of the error in the measurements, look at the time above MRC, much less than those. So I would suggest aggressive targets for organisms in ICU. I'll come back to those targets a little bit later, but let's look at the pharmacokinetics of drugs. In other words, the numerator of that drug level MRC equation. Now, it's important to understand this slide. Drugs are often discovered in a test tube or somewhere else and then put into either in a test tube or in a computer, and are put into animals initially to look at toxicity primarily, because if that drug that's been discovered is toxic to animals, it obviously cannot be progressed further. From those equations and from that experiment and maybe some other equations, the companies would take a drug and put it into phase 1 trials, in other words, volunteers who are not sick, to find the dose and to find if there are any human toxic effects. So they often are given to volunteers, or in fact, they have to be given to volunteers to test both the pharmacokinetics, get more accurate pharmacokinetics, and to look at any toxic effects. And then they often go into phase 2 and phase 3 trials, where it goes into sick patients that are not in ICU. It's no use trying to initially launch a drug in ICU, because some patients are going to die in ICU anyway, and that's not good for the drug or good at all. So it's often non-sick, but non-ICU, but sick patients. In ICU, antibiotic regimens are derived from, as I said, non-sick human volunteers, but the ICU patients have much different liver and kidney function, and it is not the same pharmacokinetics as the original phase 2 studies. And it's not difficult to see from this type of graph why the pharmacokinetics in ICU are so different. We use a whole lot of infusions, we use a whole lot of other things in ICU that will alter the normal distribution of drugs and make it different to the phase 2 relatively non-sick patients. And the first problem in ICU is this huge volume of distribution change in some drugs in ICU. And you often see when a patient comes in and you just volume load them, they swell up and become this huge extracellular fluid base of the really sick patient. When you start off with these really volume excess patients, you have to give a loading dose of the antibiotic. In other words, you have to fill up all those spaces. And I'll show you which drugs particularly need a higher loading dose. Because if you don't fill up those spaces, you'll be underdosing. And once you underdose, organisms will become resistant. And we showed many years ago that no matter what drug is exposed to the bacteria, if you don't give enough to kill the bacteria, the strong ones will grow up, a Darwinian principle, and will become resistant. So you really need to give loading doses, and they are different to maintenance doses, particularly for the hydrophilic group of drugs, vancomycin, beta-lactams, as against the lipophilic or antifungal agents that go into all tissues with a large volume of distribution, probably don't need a loading dose. But the beta-lactams, you probably should have a loading dose. Certainly the aminoglycosides, you have to have a large loading dose to fill up all those spaces, independent of, for example, kidney injury. So even if a patient is in renal dysfunction and you don't give a loading dose of aminoglycoside, you're going to be underdosing. Once you've given that loading dose, you then look at maintenance doses, which will be dependent on either renal dysfunction, normal renal function, or this augmented renal clearance. The two commonest changes in pharmacokinetics in ICU are this increased volume of distribution because of that swelling that I showed you, and increased clearances. And many years ago, we showed this diagram where there's no question in ICU that some patients will have end organ dysfunction. And if you don't decrease your dose, you'll have high toxic levels. There'll be some patients that have normal function, and you have to give the standard doses. But there's a group of patients in ICU that as I showed you, leaky capillaries, increased volume of distribution, that unless you give a loading dose, you're going to be underdosing. And there's the same group have often increased cardiac output and increased clearances of a drug. So let's look at this increased clearance in more detail. I did 2 studies many years ago, one on cefepime and one on cefparo. And it seemed that the cefparo patients always had lower doses, lower serum concentrations of cefparo than the cefepime patients. And they were the same type of drug, they should be distributed the same, they should be excreted the same, the dose is the same. And then I realized that if you looked at creatinine clearance on that axis and drug clearance on that axis, and this is measured creatinine clearance, 8-hour measured creatinine clearance, there'll be a straight line curve. Now this slide is important. You and I, if we haven't got renal dysfunction as we sit here, have a creatinine clearance of about 80 to 100 mils a minute. And we'll have this amount of clearance. We know that with renal dysfunction, when creatinine clearance is less, you have to decrease your dose because clearance is less. But there's a group of patients in ICU that have this huge creatinine clearance, double normal, sometimes triple normal, that have this huge creatinine clearance. And if there's this big creatinine clearance, there'll be large drug clearance. Large drug clearance with the same dose will create low troughs. And we arbitrarily called that creatinine clearance of greater than 130 mils a minute as augmented renal clearance. And it's taken us a while to work out now, but you have this inflammatory response, be it infection or burns or surgeries, this inflammatory response with vasodilatation and increased cardiac output. We often give patients increased fluids to raise their blood pressure. And if the renal blood flow is normal, in other words, if no renal dysfunction, there'll be increased glomerular filtration rate and therefore increased clearance of a drug. We then asked the question, how often does this occur? And we used 4 ICUs, one in Portugal, one in Singapore, one in Hong Kong, one in Brisbane. And we asked the question, patients that come in with a normal serum creatinine into multidisciplinary ICUs, how many have augmented renal clearance? Normal renal function into ICU, and we measured on a time basis creatinine clearance. We found 65% of patients that come into an ICU, multidisciplinary ICUs, with normal serum creatinine will have augmented renal clearance. There's a group in Belgium that asked a slightly different question. They also have a multidisciplinary ICU, and they asked the question, of all the patients on antibiotics, how many in this multidisciplinary ICU have augmented renal clearance? 50% of their patients had augmented renal clearance. It's often in the younger patients with an inflammatory response, but with normal or renal function, in other words, normal serum creatinine. Particularly those patients that need this huge fluid loading to maintain a blood pressure or inotropic support. We then looked at measured creatinine clearance against the formula, the EGFR or Cockcroft-Gould formula. And the formula worked well for renal dysfunction. That's where they were designed for, creatinine of 400 milligrams per liter will have X clearance. And if the creatinine is 200, they'll have a higher clearance. And if the creatinine is 150, they'll have an even higher clearance. So the clearance calculations from the formula are good for renal dysfunction. None of that database that we on for EGFR or for Cockcroft-Gould were done in the augmented renal clearance group. So creatinine clearance extrapolated from this renal dysfunction to patients with normal serum creatinine is not accurate. And this has been reviewed, and this is probably the most recent review on augmented renal clearance. 2022, and they showed that the estimation of creatinine clearance using mathematical estimates grossly underestimates the prevalence of ARC in the critical ill. In other words, you should be measuring creatinine clearance rather than calculating from formula. I know a lot of people do, but an 8-hour creatinine clearance is not that hard in an ICU. If you have this augmented renal clearance, what you've got to do is instead of a BD dose, you probably should increase the dose to 8-hourly. Or if it's an 8-hourly dose, you probably should increase the dose to 6-hourly. You've seen the slide before. It's the pictorial representation of sepsis, and it becomes even more complicated when you have extracorporeal circuits that'll have different clearances. So we think we're clever. We put a semi-permeable membrane across the blood. We take off the bad guys dialyze them with ultrafiltrates, and there's no question that we clear some of the bad guys. The creatinine gets cleared, but at the same time, the drugs and other molecules get cleared. And then we clever because we can do CVVH, we can do CVVHD, we can use CVVHDF, we can use SLED, we can use SCUF, and we think we're clever because we all clear creatinine well, but at the same time, you're clearing the good guys, the antibiotics, and it's difficult to work out dosing in those cases. So we did a large international study that we started analyzing, the SMART study, but it looks like the higher your ultrafiltrate, the more fluid you get off through the kidneys in ultrafiltrate, the higher your clearance. But it's still unknown exactly how to dose in these cases. So we suggest, if you can, to use therapeutic drug monitoring. That's the best way we can suggest to measure the PK of various drugs. And the way you use TDM is to maximize efficacy or to minimize toxicity. And aminoglycosides and vancomycin have TDM because the toxicity is quite significant, and people are using TDM to minimize toxicity of these drugs. But in ICU, it's so complicated with increased blood flow and increased creatinine clearance in burns and capillary leaks with volume of distribution and CRRT, etc. So we strongly suggest you use TDM, but I realize that not everybody uses TDM. So we are using the TDM in beta-lactams to maximize the efficacy of the beta-lactam. And here's a position paper from various societies quite recently on the place of TDM. And I'd advise you all to look at this large authored paper. Let's just go back to this yellow curve where serum levels increase over time. Let's just look at the issue with resistant organisms. So if that's an MRC, but if the organism becomes a little bit more resistant, the time above MRC increases. And if it becomes even more resistant, the time above MRC decreases. And if it becomes even more resistant, time above MRC decreases even more. And hence, we would use both probably higher doses, but increase the frequency of this beta-lactam because of this time above MRC shortening with resistant organisms. And hence, I suggest you use aggressive targets for a lot of the ICU patients. I gave a talk to the European Society of Intensive Care Medicine about using off-label antibiotics, and I think we use off-label antibiotics certainly every day, probably in about 60 or 70% of patients in ICU are using off-label drug dosing. Exactly how you target your beta-lactam is still debatable. Some people want time above MRC of 40%, 50%, 60%. We use 4 times MRC for aggressive antibiotic use And I'll show you that in a minute. We also asked the question in a multidisciplinary, in a large survey, how do you increase your dose and what do you use for your PD targets? And they said 100% time above MRC. Some people said 100%, 4 times MRC and higher. And we would use 100%, 4 times MRC for most of our dosing. And the reason for that is that it's all very well for clinical cure, and that's what you want, but you also want to decrease resistance, and that needs a higher dose than even the pharmacodynamic endpoint for clinical cure. I'll point out to you that if you do underdose or if you don't dose adequately, organisms will become resistant. In conclusion, ladies and gentlemen, package inserts are not widely generalizable into the ICU population. Guidelines take a long time to be developed, although we are trying to help the European Society of Intensive Care Medicine to do guidelines. To optimally dose, you've got to understand MRC determinations and breakpoints. And we, who are able to measure beta-lactam TDM, use aggressive targets of 4 times MRC for the whole dosing interval. And there's a little bit of experimental data showing that synergistic double gram-negative cover may be of benefit. If you are unable to measure drug levels, I'd suggest that you shorten your dosing interval from, instead of maybe 12 hours to an 8-hourly dose, or instead of 8-hourly dose, use a 6-hourly dose. If you can't measure, but certainly you need higher doses than normal for resistant organisms. So if you look at the slide over here, those are the time above MRC and the decreasing time above MRC for increasing MRCs, in other words, resistant organisms. But the same thing happens with aminoglycosides. So if that's MRC organism and that's time above MRC there, Cmax to MRC is that as the organisms become resistant or the organisms are resistant, time above MRC drops and Cmax to MRC also drops. The problem is that there will never, or probably won't be RCTs on multi-resistant pathogens because they're not enough to have RCTs. Extrapolation from surrogate outpoints will continue to occur. And at an experimental level, we're using hollow fiber infection model to predict dosing that we'll take in to prevent, to optimize dosing and to prevent resistance that we'll take into clinical trials soon. And the other group of the other method we're using is inhaled antibiotics for lung infections. Thank you for your time and attention.